Hello and welcome to Triage, rapid legal lessons for busy healthcare professionals, a podcast created and produced by K&L Gates. Each episode is designed to highlight important developments in health law and analyze the impact on our clients and friends of the firm. We hope you enjoy this podcast.
Thank you for joining us today. My name's Carla DewBerry, and I'm here with my colleague, Kelsey Jernigan. We're both members of the healthcare section of K&L Gates, and we actively focus on healthcare issues impacting mental health providers. Today, in this episode of Triage, we intend to discuss mental health parity in the context of recent legislation in California, which we'll use to frame our discussion. This new legislation has sparked a renewed discussion of what mental health parity is and how it should work. We define mental health parity as requiring comparable coverage for behavioral health treatment as compared to physical health or medical treatment. To set the stage for this conversation, we note that a 2019 survey by the Kennedy Satcher Center for Mental Health Equity at the Morehouse School of Medicine, in conjunction with the Kennedy Forum, reported that many states, including California, whose new statute we're going to discuss, received a failing grade for mental health parity policies. In fact, only 5 states received a grade of C or better for their mental health parity laws. Those included Illinois, Tennessee, Maine, Alabama, Virginia, and New Hampshire. Kelsey, with that backdrop, could you first introduce yourself? And then can you tell us a little about the federal laws regarding mental health parity and why California needed its new legislation?
Thanks, Carla. This is Kelsey Jernigan in the firm's RTP office. As Carla mentioned, the California legislature has passed a bill making significant strides in efforts to ensure parity in mental health and substance use disorder treatment. Specifically, the California Senate Bill 855 was approved by the legislature and has been presented to the governor on September 9, 2020. As of the date that we're recording this podcast, the governor has not yet signed the bill. A keystone of the federal landscape of mental health parity is the Mental Health Parity and Addiction Equity Act of 2008, which was passed to strengthen the initial Mental Health Parity Act of 1996. In 2009, the Affordable Care Act extended the scope of that 2008 law, in part by including mental health and addiction coverage as one of the 10 listed essential health benefits. In describing the need for changes to the state's existing mental health parity law, the California legislature acknowledged that both a federal statute and a state statute existed to require parity for mental health and substance use disorder services. However, the California legislature indicated that while the Affordable Care Act included mental health and addiction coverage as an essential health benefit, the ACA did not actually define medical necessity, which allowed payers to deny needed mental health and addiction coverage through overly restrictive medical necessity determinations. Further, California legislature emphasizes that the significant need for reform and points to the prevalence of mental health disorders in the country, noting 1 in 5 adults experience mental health disorder and 1 in 13 individuals who are 12 years old or younger experience a substance use disorder. The bill states that when mental health disorders and substance use disorders go untreated, individuals' conditions worsen and the individuals become a cost to taxpayers through the Medicaid program, criminal justice system, and the homeless population. Lawmakers also noted that expanding the state's mental health parity law will help to address manifestations of the ongoing mental health and addiction crisis in California, including increasing opioid overdose rates, increasing suicide rates, the correlation between untreated mental illness, substance use disorders, and incarceration, and the connection between mental illness and dropout rates.
So, Kelsey, let me stop you for a second. Just a moment ago, you mentioned medical necessity. The health study, which I referred to at the start of this podcast, addressed processes which plans use to determine when treatment will be covered as one of the things which they graded in their study. Those techniques often include medical necessity reviews, prior authorizations, and step therapy protocols. Can you tell us a little bit about the new California law as it addresses these protocols? And also, maybe you could put it in the context of some of those recent California cases dealing with medical necessity determinations.
Sure. Recent cases in California state court have held that the California Mental Health Parity Act requires coverage of medically necessary residential treatment and have further examined level of care placement criteria as being inconsistent with generally accepted standards of mental health and substance use disorder care. As such, the California legislature attempted to address these issues by amending the state's Mental Health Parity Act. In part, if the bill is signed by the governor, the California bill would require a health care service plan contract or disability insurance policy that's been issued, amended, or renewed since January 1st, 2021, to provide coverage for medically necessary treatment of mental health and substance use disorders under the same terms and conditions that are applied to other medical conditions. The bill would prohibit those same healthcare service plans or disability insurers from limiting benefits or coverage for mental health and substance use disorders to short-term or acute treatment, and revise the list of covered benefits that are detailed in the existing state law to include basic healthcare services, intermediate services, which include the full range of the levels of care, including residential treatment, partial hospitalization, and intensive outpatient treatment, and to include prescription drugs if the policy includes coverage for prescription drugs. The bill would also require a health care service plan or disability insurer that provides hospital, medical, or surgical coverage to base medical necessity determinations on current generally accepted standards of mental health and substance use disorder care that are developed by a nonprofit professional association for the relevant clinical specialty. Utilization review criteria that's applied by the plan or insurer to determine medical necessity of healthcare services and benefits will also be required to be based on those same generally accepted standards. If the bill is signed by the governor, healthcare service plans and insurers will be required to apply those specified clinical criteria and guidelines in conducting utilization review and would be prohibited from applying different, additional, or conflicting criteria than those criteria and guidelines that are in the specified sources, with very limited exceptions. In order to ensure that these guidelines and criteria for medical necessity and utilization review are applied consistently, the bill requires every healthcare service plan to sponsor a formal education program to educate the plan staff, any contracted third parties who perform utilization review, and other stakeholders. Plans would also be required to provide that documented clinical review criteria and training materials to the health plan's enrollees and to healthcare providers enrolled in the plan as well. In addition to the education, the bill requires health plans to track and analyze how that criteria has been applied and to conduct testing to ensure that it's been applied consistently. Similar provisions are included in the bill that would apply to disability insurers providing hospital, medical, or surgical coverage. Finally, the bill provides that if a healthcare service plan contains a provision that reserves discretionary authority to the plan to determine eligibility for benefits or coverage, to interpret the terms of the contract, or to provide standards of interpretation or review that are inconsistent with state law, then that provision reserving discretion is void and unenforceable. One thing to note is that this provision is not limited to the mental health and substance use disorder context and seemingly prohibits health plans from reserving discretionary authority to determine eligibility for coverage of any services. This provision adopts as California law concepts that have been acknowledged in prior state regulations and prior state and federal court cases.
So, Kelsey, let me just take a second and talk about what we've seen occurring in other states. The California bill comes amid efforts by many states in the last year to strengthen their own mental health parity requirements. For example, in March of 2020, the Arizona legislature passed a bill, which was signed by their governor, that requires insurance companies to conduct and file an analysis with the State Department of Insurance, demonstrating their compliance with the federal parity laws, as well as providing funding for behavioral health services in schools. Oklahoma has also acted. It enacted a law empowering the Oklahoma Insurance Commissioner to assess and ensure that all in-state health plans comply with the federal mental health parity law, and further requiring insurance companies that offer mental health or substance use disorder plans to report annually to the insurance commissioner as to the process by which they determine the criteria for mental health benefits and the criteria for medical and surgical benefits. And in February of this year, Massachusetts' Attorney General settled with 5 large health insurance companies over allegations that the insurers violated the state's mental health parity laws. However, with the express requirement to provide residential and intermediate coverage, the prohibition on reserving discretionary authority to the health plan, and the specific requirements to rely on generally accepted treatment guidelines and criteria, California's law seems to set the standard for stricter mental health parity than many of the other laws at issue in the country. And all this is happening in the context of the COVID-19 pandemic. As we all recognize, during this pandemic, there has been a resulting economic recession. Individuals have been negatively affected with respect to their mental health by things such as new barriers with respect to social distancing and isolation, job loss, and overall economic downturn. So it's surprising to see this kind of large change at this point in time. But we've also seen during the pandemic some other changes which likely advance access to mental health services. For example, we've seen wider coverage for behavioral health services provided via telehealth, and changes in payment policies which allow the same rate of payment for remote patient care as compared with in-person care. I think we're going to have to wait to see whether California's policies are enacted and signed by the governor and whether they impact the transition for greater mental health parity in other states. I also note that, as you stated earlier, that portions of this law become effective on January 1, 2021. That's not very far down the line, especially for insurance companies that are likely already going through the process of setting rates and predicting the economics of their plans. So it's an interesting transition in California. We'll have to keep our eye on it. I don't know if there's other things you wanted to comment on, Kelsey, or should we just call it a wrap?
I think that is comprehensive coverage of the bill in California and what's going on the state level. So I think it makes sense to wrap up for now. Thanks, Carla.
All right. Nice talking to you. Bye.
As well. Bye.
Thanks again for listening to Triage, rapid legal lessons for busy healthcare professionals. New episodes are available for download through iTunes, Google Play, and other podcast applications. By subscribing to Triage, you will receive timely notifications of each new episode. Also, if you have any topics that you would like to hear discussed on Triage, please don't hesitate to email triagesupport@klgates.com. We would love to hear from you.